I'm Dr. Nitin Burkule from Mumbai. We have a very exciting topic here about the myocardial imaging. With me, we have got very distinguished panelists. On my right is Dr. Jagat Narula. He is the Director of Cardiac Imaging at Mount Sinai Hospital, New York, and also is Associate Dean with the ICANN School of Medicine. And we have Dr. Jeroen Bax. He is the Director of the Echocardiography and Non-Invasive Lab at University of Leiden, and as you know that he is the past President of European Society of Cardiology. Welcome you on the CSI TV. We will start with the tremendous progress that has been done in the multimodality imaging of the myocardium, the echocardiography, the CT and the MRI, and we will see what promise it holds, what the technology has achieved now and what promise it holds in future. So we'll start with the echocardiography, and as you know, the nuclear kid on the block has been the deformation imaging by speckle tracking echocardiography. And I'll ask Dr. Jeroen, what is the current status of the global longitudinal strain in echocardiography, whether it has really shaken the pedestal of ejection fraction, where exactly the clinician should be using it, and what is the future promise with the speckle tracking echocardiography. Dr. Jeroen.
Well, thank you very much. It's a pleasure to be here, and I think the strain is something that has become very useful for us. We are used to measure left ventricular performance by looking at ejection fraction. And ejection fraction, if you carefully analyze, is basically nothing different than the amount of volume of blood that's in the ventricle and the amount of volume of blood that's leaving the ventricle during systole. So the ratio of what is in and what goes out is what determines the ejection fraction. So the ejection fraction is not directly reflecting what is happening in the muscle. And if we talk about how good or how bad one's heart is performing, the first thing that we ask is what is the ejection fraction? But you will start to realize when you look at patients, let's say patients that have had radiation for oncology or they had chemotherapy for oncology, the ones with a, let's say, almost normal ejection fraction, if you look at the strain, which is the deformation of the myocardium, which is really showing what's happening in the myocardium, then you see that often where the ejection fraction is normal, that the strain has already become reduced. So the strain is more sensitive because it depicts what actually is happening in the muscle and is not dependent on loading of the ventricle. The other where you could use it very well is when you have a very low ejection fraction. So we just discussed about high ejection fractions, normal ejection fraction, where strain can already show that something is going on. I gave you the example of radiation or chemotherapy, but there's also the issue of severe aortic stenosis, where your ventricle seems totally normal, but if you do the strain map, you see that the strain is already reduced. Now let's go to the other extreme where the ejection fraction is very low. That can be, for example, in mitral regurgitation, severe mitral regurgitation. When we see a heart that's moving like this, then we see an ejection fraction that's still 30%. And you ask yourself, that cannot be, because the heart is not doing anything. But if you look then with ejection fraction volume in, volume out, you see that half of the volume out goes in the left atrium. So this is not the performance of the ventricle. This is just volume that is in and volume is going out. If you measure the strain in severe mitral regurgitation, despite the relatively okay ejection fraction, you see that the strain is way, way, way reduced. So I come to the point that in the very high ejection fractions, the very low ejection fractions, strain gives us more because it shows to you what is really happening at the level of the myocardium. So we need to start thinking different, no longer looking at ejection fraction, but asking ourselves, how well is this muscle of the ventricle performing? And if you do that, you come to strain and you see that it's quite often different than an ejection fraction.
Let me ask a question, Nitinji, from Jeroen. GLS, as you know, are the global longitudinal strain, as you very well know, not the regional one, but essentially the global. And all that is just based on the convenience of measuring it. And leaving aside the convenience, what do you think? How exactly would you be able to add the global circumferential strain on it or regional circumferential strain on it? Because no ventricular mechanism will be complete unless you bring in the circumferential forces. I'm not bringing in the radial forces, but I'm bringing in the circumferential forces, number one. And number two, would you really like to involve the vortex velocity also into it as to how exactly the blood transport occurs through the ventricular chamber? Would that be able to assist us and make the strain as a more complete parameter?
Well, thank you. For the moment, we're just learning that there is more than ejection fraction. And by doing that, we start understanding what is ejection fraction. As I said, volume in, volume out. So we're shifting away from the volume shifts going to the ventricle and really looking at what's happening in this ventricle. If we start doing that, we started with the longitudinal strain, which is the up and down deformation. But as you rightly point out, there are two other forms of strain. One is the inward strain, which is what we call the radial strain, and one is the rotational strain, which is called the circumferential strain. So for the complete picture of a heart, like Torrance Guasp already indicated, we need to look at the up and down, the inwards, and bring it together with the deformation in the circumferential region. If you want to have eventually the full picture of a ventricle, what it's doing, you need to combine those three. For the moment, for convenience, we're just starting with the longitudinal global strain. But you anticipate rightly that in the future we start to think three-dimensional, and with the three-dimensional comes these other two forms of strain. It's quite complex, so we should not make the things too complex and keep it practical. For the moment, what I advise to you is the global longitudinal strain is more sensitive than an ejection fraction, because it focuses on the muscle. If you want to make steps forward in the future and you want to understand certain pathophysiologies better, maybe predict outcomes even better, you could anticipate that we're going to use these three types of strain in an integrated model which drives us in the direction of three-dimensional imaging.
That's great, Dr. Jeroen. Since we are on the myocardial imaging, as you know that you are also an expert in CMR, we know that the new things that in the CMR advances have been the established role of late gadolinium enhancement and also the evolving role of T1 mapping and the extracellular volume mapping. So can you just give an insight for the clinical cardiologist, what does actually the T1 and ECV mean? And then I'll go to Dr. Jagat Narula and I'll ask him whether all these three modalities, how they help us in differentiating the cardiomyopathies. So Dr. Jeroen?
Yes, very good point. I believe that every disease has three components. It has an anatomical component, anatomical abnormalities. These are then superimposed or resulting in, I should say, in a functional abnormality. So let's take, if you have a stenosis in your coronary arteries, then the functional consequences are a reduced FFR. Or let's say if we have scar formation, the functional consequences is a reduction in function. So you have an anatomical component, then you have a functional component, and the third component is an inflammatory component. And every disease is characterized by these three components. Now if we talk about CMR, CMR is very good in anatomical assessments. So we have learned to work with the late gadolinium enhancements. Using the contrast, we see very clearly on an MRI this white dense tissue, and that is macroscopic infarcted tissue or macroscopic fibrosis. The more we have been starting to use the T1 mapping, which is a non-contrast imaging, we actually see that there is differences in extracellular volume. And extracellular volume means more fibrosis. If the cells disappear and extracellular volume gets bigger, means that more fibrosis is becoming. We cannot visualize that, but we can measure it with the T1 mapping. And so let me give you two diseases. If we look at severe aortic stenosis, the walls get thicker and thicker, you get septal hypertrophy. As a consequence, the perfusion is not supportive enough for this thickened wall. So what happens? You get mid-wall fibrosis formation. That's one where the T1 mapping is excellent. The other one is mitral regurgitation. There it's not a pressure overload like aortic stenosis, but it's a volume overload like mitral regurgitation. So ventricle dilate, dilate, dilate. At some moment the ventricle cannot handle anymore and it's becoming too stretched. So fibrosis is going to be formed. So these two are excellent examples of where the T1 mapping can help us seeing if this ventricle is still okay or too much fibrosis is coming. Late gadolinium is visual, what you see, the white, dense, macroscopic scar. Fibrosis formation with the T1 mapping, measuring extracellular volume, reflecting the amount of fibrosis you cannot visualize, but you can quantify it. And I believe that if we want a better time, for example, when we need to change the valve in aortic stenosis, when we need to repair or replace the valve in mitral regurgitation, we need to understand how much fibrosis there is in the ventricle. And that's where T1 mapping is going to play a big role.
So it's pertains to the myocardial health in that individual patient. That's a very good point. I'll come to Dr. Narula because he has given us a new classification of cardiomyopathies. So how does this MRI helps, especially in the diagnosis and prognosis of various cardiomyopathies?
Excellent question, Nitinji, again. So as Dr. Bax just suggested, that this difference in the relaxation times between the myocyte compartment and the interstitial compartment, that gives an excellent index of prognosis in the patients with cardiomyopathy. Now, as you very well know, that T1 mapping, native T1 mapping, does even better than the late gadolinium enhancement, specifically in the dilated varieties, where you may not have a significant amount of replacement fibrosis and you may have the extracellular volume expansion. Now, it is our belief that every patient with cardiomyopathy at least has to have one CMR in his or her lifetime. It is extremely important that we characterize these patients. It will not only be able to ensure the type of cardiomyopathies that we are talking of, it will also be able to prognosticate. It probably would be able to help us in identifying the people who are likely to benefit by the defibrillator therapies or some of the other areas which could be specifically addressed, specifically in the types of cardiomyopathies which may have specific telltale features of cardiomyopathy.
Excellent. So I think if we take a classical example of say hypertrophic cardiomyopathy, then I have a question for both of you. How does the echo and MRI is going to help us in deciding about the say ICD therapy and also for prognostication?
So I think that the scar formation or the fibrosis formation is probably a trigger for electrical instability. And electrical instability translates probably in ventricular arrhythmias, and ventricular arrhythmias could result in sudden death. So if we want to use the ICD to counter that, then probably one way, and people are building evidence at the moment, one way to risk stratify who would benefit from ICD therapy, let's say in ischemic cardiomyopathy, would be measuring the extent of scar tissue. One way to do it in a non-ischemic cardiomyopathy would be by measuring the extent of fibrosis, the non-visible fibrosis at the T1 mapping. There is already some small studies indicating that, but it's still not enough in guidelines to support that. I believe that guidelines are very good, and we need to have evidence to support what we're doing. But guidelines are very large trials, and if you look within these large trials, you always have different phenotypes who respond differently. So the counterpart of guidelines, if you like, is the personalized medicine.
Yeah.
And if you want a more personalized medicine, the way to go forward is better phenotyping the substrate of the disease. And if you want a better phenotype substrate of the disease, you come to imaging. So I believe that this imaging may help on top of guidelines that exist to better phenotype, to avoid that we implant too many ICDs in patients that don't benefit. And at the same time, we could look at patients with a higher ejection fraction where there is already significant fibrosis, considering that they may be candidates for ICD therapy as well. So it will better allow, hopefully in the future, selecting the patients that have the most benefit from ICD implantation.
So I will add on that essentially, and that is what you exactly wanted me to speak about. So as Dr. Bax just suggested that we have to characterize the cardiomyopathies better so as to have the ICD therapy and all, I would say that essentially the basis of this phenotype is obviously the genotype.
True.
Right? So ESC actually in their guidelines have already started approaching that topic. We haven't started doing that as effectively in the ACC and AHA guidelines, but ESC specifically when we talk about the hypertrophic cardiomyopathy, they have started to talk a lot about it. For example, a patient with myosin defect in hypertrophic cardiomyopathy, like with the myosin heavy chain defect and all, you require a significant amount of myocardial hypertrophy to occur before you are advised or you are recommended to have the defibrillator therapy. On the contrary, in cases of troponin defects or troponin genotype here, you may need a very little amount of a hypertrophy and still the patient may have more arrhythmogenic potential. So basically we would need to characterize it, we will need to balance the genotype or phenotype, and exactly as Jeroen just said about the dilated cardiomyopathies, for example, in the patients with dystrophinopathies, in the dilated cardiomyopathy, you may not require, even if the ejection fraction is lower, although by the guideline, we are bound to give the defibrillators, there may be a reason to consider or reconsider in these patients because they may not be as amenable to the arrhythmia as a patient with Lemon cardiomyopathy will be. So a patient with Lemonopathy, even at 45% ejection fraction, may be a candidate for the defibrillator therapy, but as the current guideline stands, this patient has to die first to be able to deserve a defibrillator. So essentially it will have to be a combination of, as Dr. Bax just said, the phenotype, and we will really need to go further with the genotype also. So we need a more comprehensive picture when we need to make the decision. So obviously we are not there.
True.
And guidelines are still not there. We really need to work towards it.
True. So the imaging is going to play a very important role in the management of these cardiomyopathies. So I think we'll shift the gears and enter into the CT imaging of the heart. Now from the clinical cardiologist perspective, what is the role of calcium scoring of the coronaries for risk stratification of an asymptomatic individual? So when should a clinician ask for a CT calcium scoring and what it impacts his decision making in managing the patient? Dr. Jeroen?
Okay, so the calcium score is the easiest way of looking at the CT scan. You just look at the amount of calcium being present. One of the things that I think is very important, you started with the word asymptomatic. If you have patients that are symptomatic, you should not use the calcium score because those patients may present at a very early stage of coronary artery disease and have non-calcified lesions, which may be, as you will indicate later, more vulnerable.
True.
So stable patients, either symptomatic or asymptomatic, you can do a calcium score as a first test. I think it's a very good test. I think it's a test that shows immediately how much calcium is, which is a surrogate marker of the amount of calcified atherosclerosis there is in a coronary artery. And the more it is, the higher your likelihood of eventually cardiovascular events. That has been shown. I think as a first screener, it's perfect. You can use it both in symptomatic patients as a rule in, rule out, but you can also use it in asymptomatic patients because if patients are at high risk, multiple risk factors, we have learned indeed that the majority do have calcium, but there's also a part, maybe 20%, that do not have any calcium at all. Strange enough, you can have a lot of risk factors, but still have no atherosclerosis calcified.
True.
So I think it's a very good first risk marker, in which patients, I think we start using it more and more at a very low thresholds. And in some countries, patients can self-refer because they're worried about their health. I think this is not a bad development because people are engaging in being responsible for their health. So they want to see what's going on. So I think, just to summarize, it's a very good marker of the extent of atherosclerosis calcified in your vessels, and you can use it in symptomatic and asymptomatic patients as a first screener.
True, and once you have a visual impression, it will definitely impact your lifestyle and also probably escalate the use of statins.
Absolutely.
Now the thing is, from the CT calcium score, as we know, the CT has advanced to an extraordinary imaging of coronaries, and now we have reached a stage where we are having plaque characterization and also the CT FFR imaging. So I'll ask Dr. Narula, where exactly in the management pathway of the ischemic heart disease patient, where exactly this piece of CT FFR fits in a clinical cardiologist practice?
So, well, I think I'll have to slightly rephrase your question here.
Yeah.
And I would say that when you are talking about the CT angiography, I truly think that there is a lot to consider about the CT angiography in the stable coronary artery disease patients, and for the decision about the revascularization in these cases. Now, the revascularization in the patients who have a stable disease has been quite contentious, as you know. Now, to the extent that last year when the Orbiter trial came in, it almost told us that the stents are not going to be helping us. On the contrary, we have seen it for the numbers of years, or rather decades, that the coronary revascularization did well in the patients with triple vessel disease, specifically with the included left main disease, when there was the inducible ejection fraction, inducible ischemia or low ejection fraction in these cases, that the revascularization did better than the optimal medical therapy, which was time sensitive optimal medical therapy. It may not have been the same what we have today. Now, when we do these studies in today's day and age, as you have seen in the Courage trial or as you have seen in the Barry 2D trial, that this did not succeed. The revascularization was something similar to what the optimal medical therapy was, and that is the time when we started to realize that is FFR the way to go? Should we be looking at the functional impact of the stenosis and go with that? And then came the FAME family of trials, both the FAME and FAME2, that clearly told you that the fractional flow reserve determined or guided therapy or revascularization was superior to the angiographically guided therapy. And not only that, if the FFR was abnormal, if you treated them with medical therapy versus with the revascularization did particularly better. However, if you really tease the data of the FAME study, and also was later on confirmed by the FAME2 also, the essential advantage of the FFR was when we looked at the people who had normal FFR, that the people who had normal FFR did quite well. Not that all the people who have got the abnormal FFR are likely to have the event. The likelihood of event is going to be approximately 8%. So positive predictive value would be to that range, while the negative predictive value was to the tune of 2 per 1,000, in the sense that 2 people will have an episode out of 1,000 people if you really had a negative FFR. So FFR brings us quite close to a ideal negative predictive value. Now, why is it that the positive predictive value is not as good? That happens with all possible tests that are available to us. They all have a lot to do, because for an event to happen, you really require a perfect storm. There are multiple things that have to converge so as to create a situation where the person is going to result into an event. And most important out of them happens to be the plaque characteristic, as you mentioned, that the patient has to have a plaque which is a vulnerable plaque or a high risk plaque. Now the question here is that every high risk plaque is going to result in the same thing? No. Again, the same thing, the positive predictive value for the plaque ranges between somewhere around 12% to approximately 25%. But essentially, again, it correlates with the FFR. If the plaque is not a high risk plaque, the FFR is going to be normal. Right?
Yeah.
So it is a good surrogate for that. If the plaque is abnormal, it is likely to give you an FFR which is abnormal. So something which is sitting in the lumen, that is the luminal stenosis, or something which is sitting outside the lumen, which is the large low attenuation plaques, they basically contribute to the abnormality of FFR. And I mean, we recently suggested that, but I would like to mention that Jeroen happened to be one of the first people who had proposed this concept, and I remember having taken that paper for the JACC imaging when there was so much of an opposition because he was going against the stream of what is currently believed. So basically, are we going to be able to say that FFR gives us an outstanding negative predictive value? Should we be able to exclude those patients who are likely to do very well, regardless of the amount of these stenosis, who are likely to do very well on the optimal medical therapy and proving what the COURAGE and the Barry 2D trials showed us? So, as it stands, CT-FFR would be able to give us or CT angiography should be able to give us a triply effective phenomenon, including all the stenosis of the plaque, or stenosis induced by the plaque characterization, which is likely to contribute to it, and finally the FFR also, making it probably a preferable therapy or preferable diagnostic modality which we should explore further. I do not want to compare them to the functional status and all because we have seen multiple trials, but I would stop there by saying that this has immense potential which needs to be fully evaluated in the coming days.
Excellent. So it's the plaque characterization and the FFR will be a very strong point of CT imaging for deciding the prognostication and the outcome of the patient. So I think here we'll again go back to the CMR. And so what do you see the role of CMR in deciding the culprit lesion, especially in the non-ST elevation MIs, where you are not very sure about the culprit vessel, and as we have seen from the FEM trials that unless you revascularize only the culprit vessel, your outcome is not that good. So can you elaborate on that?
Yeah, I think the non-invasive imaging in general is very good in assessing again the functional consequences of the anatomical significant lesion, responsible lesion if you like. And what we can do with the non-invasive imaging is look at the consequences of what's being developed is ischemia. And the ischemia we can measure in different ways. We can look at the changes in regional and global ventricular function, including strain, changes during stress. And we can also look at the changes in perfusion following a stressor. So we can do either functional or emotional imaging, or we can do ischemia imaging in terms of perfusion imaging. You can do that with any technique. You can do that with a nuclear scan, you can do that with an echo, and you can do it probably the most high resolution with an MRI. And if your question is specifically which territory is the problematic territory relating to this or that vessel, and probably your first choice would be an MRI. I know that from the Danami sub-study, they have one article coming soon on the use of this. So MRI looking either at dobutamine-induced wall motion abnormalities, but maybe even preferred because it's more sensitive, is the perfusion imaging with CMR.
True.
So the CMR, if you really look at it, and specifically as you were asking about the high-risk plaques and all, the techniques are not very advanced at this point in time, not prevalent at this time, but very elegant work that comes from Japan, specifically from Teruo Noguchi's group from Osaka, where they are looking at the plaque to myocardial ratios on the native T1 mapping of the plaque. And essentially they are trying to tell us again the same story, that whenever there is the high plaque to myocardial ratio, plaque to myocardial ratio, it correlates so well with the FFR. Essentially, regardless of the stenosis, if the PMR is high, you basically find that these plaques would result in the abnormal FFR regardless of the stenosis.
Yeah.
So that is an upcoming technique which you would be seeing more often in future.
And Dr. Narula, with your nuclear imaging background, can you shed us light on what are the advances in the nuclear imaging for myocardium, which is going to change the future or the way we manage the patients?
So nuclear imaging, as you very well know, specifically with the single photon imaging, you very well know that it has the most important historical role to play in the patient management, specifically for the assessment of the ischemia. In these patients, it is time-tested technology, largest number of patients that it has been tested upon, and gives us the value. Now, essentially in the coming years, the most important expectation is that we would have the PET related radio tracers or the positron emission tomography, quite like flopyridaz and all, which are undergoing the testing at this point in time, and we might be able to identify the myocardial perfusion at a much better level with the quantitative assessment, so many milliliters per minute per gram of the myocardium. And I think the major role of the functional imaging is going to be specifically that from PET more so than SPECT, is going to be in the patients who are the patients with known coronary artery disease. Unknown coronary artery disease, probably we would be going more with the CT angiography, but the known coronary arteries, we probably would be more focused upon the functional imaging, and if the PET becomes available, it will be a great achievement. The second important area which I think is going to be picking up is the neuronal imaging. A lot of PET tracers are now coming up, quite like the MFBG and all, which are under trials, which will be able to address the neuronal component. So we have talked about the myocytes, we have talked about the interstitial imaging, but we have not talked about the neuronal imaging, which may have an important role to play both in the assessment in terms of prognosis of the patients with heart failure, as well as for the assessment of the patients who are likely to be needing the defibrillator therapy or ICDs in the patients with low ejection fraction.
Thank you, Dr. Jeroen, and thank you, Dr. Jagat. I think it was a wonderful discussion.